Hello friends, welcome back. We will talk about a little bit about the portal circulation and the significance. There are three portal systems in our body. The hepatic portal circulation, which is present in the gastrointestinal tract and the liver, and the second one is present in the kidney area around the kidneys, loop of Fenley and the vasa recta, and the third one is present in in the brain around the pituitary gland, actually. Actually, this is a special type of arrangement of the blood vessel. Um, the idea is to conserve and do not allow too much wastage or dilution of the chemical. Usually, the cells are surrounded by the capillaries. The artery bring the blood to the blood to the cell. Cell artery gets divided into smaller capillary, and then they rejoin, continue as a vein, like it's like a one way loop. But in the portal system, the capillaries from two different sources actually are surrounding the cells. The two different sources dump or drain their chemicals around the cell in such a way that one system can transfer their contents under relatively high concentration, um, bypassing the heart. Because if you take anything to the heart is going to distribute to the rest of the body, so things can get diluted. Whereas in the portal circulation, you can transfer concentrate or a highly concentrated chemical to the local area. You can exchange them under a high gradient, actually. Today we're going to talk more about actually hepatoportal system uh, in the liver and the gastrointestinal tract. This picture actually shows the splanchnic circulation, uh, the celiac artery, the superior and inferior mesenteric artery, the hepatic vein, and inferior vena cava, and general circulation around the rest of the body, around the brain, kidneys, uh, hands, and the legs. Now, the white arrows actually basically telling us the flow, giving us the direction of flow of the blood in the arteries and the veins, and the yellow arrow are showing us the flow of contents in the portal vein. Portal vein actually collects the contents from the lower part of the esophagus, upper part of the stomach, spleen, pancreas, and almost all of the intestine except the rectum. And it first goes to the liver for processing and then to the heart for circulation. If you notice the portal vein here, the return is traveling against the gravity, and there's no valve in the portal circulation. What it means, the blood can go in either direction, and that can be a problem, and we will come to that shortly. Good thing is that it's under low pressure. Now, liver, besides receiving input from portal vein, is also getting supply from the hepatic artery. Therefore, liver is basically receiving dual blood supply, portal vein as well as from the hepatic artery. Now, inside the liver, the arrangement of the sinusoidal cell is such that the contents coming from the GI tract are mixing with the arterial blood. Now, liver actually needs to process everything we eat, because you never know, there could be some toxins in the food we eat or anything harmful circulating in our blood. Now, when it's going through the liver first, before going to the heart for distribution to the rest of the body, we call it like first pass effect. Now, during first pass effect, liver wants to make sure that it's okay to send to the heart for the distribution. Liver will decide whether to send it forward, metabolize, store it, or should I eliminate it. Now, just like, for example, in our blood, we have the white blood cell, WBC, so which can basically destroy or phagocytize any foreign particle. So similarly, liver is also basically doing the same thing, is going to doing the phagocytosis with the help of the enzyme, the cytochrome P450 system. Now, in terms of the volume, I mean the percentage, the portal vein is bringing about 75% of the total blood supply, whereas hepatic artery contributes about 30% of the oxygenated blood. In this way, liver is basically receiving plenty of blood supply, and the liver can expand, it can shrink like a sponge, and it can compensate for any fluctuation in the blood. It's basically acting like a pool of blood. Now imagine all of this blood. Uh, how are we going to accommodate if there is any damage, or liver is shut down, or liver not liver says no input, so liver basically close its door to the input. So where this blood will go? The blood will All this blood will basically back up in the areas it was coming from. So and that's what happens in the cirrhosis. In the cirrhosis, the liver shrinks in size. It become hard like a stone, and this is due to fibrotic changes in the liver. And these are fundamental changes in the structure of the liver. Fibrotic tissue doesn't work; it won't allow any blood to pass through, and slowly, the pressure start building up. Normal pressure around like 5 to 6 millimeter of mercury, but good thing is this pressure is not too high. Any pressure greater than like 6 millimeter of mercury causes portal hypertension. Now, during portal hypertension, patient develop changes in the uh, blood flow pattern. Basically, there are hyperdynamic circulation changes. So instead of, for example, generalized because liver has shut down, because it has closed its door, so instead of generalized vasodilatation throughout the body, there's a more preferential vasodilatation um, around the hepatic, about around the GI tract and the portal vein versus the systemic. And this is because of the local production of the nitric oxide, cirrhosis induced nitric oxide. So there's a more vasodilatation in the portal area. Now, what happens? More blood stays there, less is going to the systemic circulation. So this leads to actually net reduced or decreased effective intravascular volume. So now, whatever blood, the kidneys need to have certain amount of blood passing through them all the time. So when the net effective circulation volume goes down, the kidney senses, oh no, there is a danger. So what kidneys do? Kidneys, as a compensation, activates the renin angiotensin aldosterone system, and the idea is to conserve fluid. So the angiotensin acts like a vasoconstrictor, and the aldosterone is going to secrete the sodium and retain some of the water. Now, there are two things to this. Angiotensin is good, going to cause vasoconstriction, which is okay because we have too much vasodilatation in part of the body. We want vasoconstriction, but it's coming at a cost, like it's causing vasoconstriction in systemic circulation too. At the same time, the RAS system activation, the sodium retention, instead of helping, it can add to the problem. So in a way, body is trying to help, but um, um, it's helping, I will say, like 50%. And there's sometimes some other factors can also add to this problem, like some of the drug, like non-steroidal anti-inflammatory drugs, any any other reason like hypovolemia or GI bleeding, peritonitis or paracentesis, they all can lead to this, can add to this problem. This ultimately leading to, uh, first it starts with the liver, and ultimately when the kidneys are not receiving enough, can cause kidney damage, leading to hepatorenal syndrome. And and um, and when it's too much pressure actually in the around the liver area on those blood vessels, the body is trying to find an alternative route to get distributed, basically to go to the heart or to be supplied to the rest of the body. And so the blood vessel in and around the esophagus, around the upper part of the stomach, they start dilating, and all this dilatation causes varicose veins or varices. The varices veins are at a greater risk of rupture, and this is one of the reasons this patient who was cirrhotic patient, they come with the uh, like um, um, blood loss or bleeding, GI bleeding. But it's important to understand the bleeding due to cirrhosis versus bleeding due to ulcer. So technically you should do the endoscopy and make sure it's due to uh, varices, and if there's varices you can do the ligation and try to um, minimize the bleeding. Versus if it's due to ulcer, then it's a different etiology, because when we're using PPI, proton pump inhibitor, if the bleeding is due to cirrhosis, varices, then PPIs are not will not be of much help, because they are we going to cut down the production of hydrochloric acid, whereas the bleeding is due to high pressure buildup in the in those varices veins. So be mindful of this fact. So another thing is when we're using the PPI, like using the drip versus IV push. If we're using the drip, look at the volume. Generally we make pantoprazole 80 milligram in 250 ml bag. So if the system is already overburdened with the volume, be considerate of this fact. So probably if you have to use PPI, maybe you can choose the PPI as a IV push instead of the drip. We try to use the vasopressor to basically help relieves the congestion. There's one chemical, there's one drug called um, um, no, normally we use the norepinephrine and albumin in United States. This drug called terlipressin, which is not available in United States yet, but it's available in Europe. The idea is to raise the mean arterial pressure somewhere around like at least by 10 millimeter of mercury. Now, because this uh, raising the pressure a little bit will will prevent the kidneys from like failure. So that's the idea behind it. And I'll continue with the hepatorenal syndrome in my next lecture, because it's a lengthy topic. So I'll continue. I'll try to stop here. I'll continue in my next session. Thank you for watching. Thank you.